Okay, yeah.
You're all set.
Hello, everyone. Good morning or evening, everybody. Today, I want to share something about the fair needle therapy for herpes zoster. Yeah, I'm Shaoxin from China. Yeah, I will do this presentation for 6 parts. The first is epidemiology. Varicella zoster virus causes two distinct syndromes. Primary infection presents as varicella or chickenpox. Contagious or usually benign illness that occurs in epidemics among susceptible children. Subsequent reaction of latent varicella zoster virus in dorsal root ganglia results in a localized cutaneous eruption termed herpes zoster or shingles. Declining virus specific cell-mediated immune responses, which occur naturally as a result of aging or are induced by illness or medical treatments, increase the risk of shingles. Over 90% of adults in the United States have serologic evidence of varicella zoster virus infection and are at risk for herpes zoster. The annual incidence of herpes zoster is about 1.5 to 3.0 cases per 1,000 persons. An incidence of 2.0 cases per 1,000 persons would translate into more than 500,000 cases annually in the United States. Increasing age is a key risk factor for the development of herpes zoster. The incidence of shingles among persons older than 75 years of age exceeds 10 cases per 1,000 person years. The lifetime risk of herpes zoster is estimated to be 10 to 20%. The other well-defined risk factor for herpes zoster is altered cell-mediated immunity. Patients with neoplastic diseases, especially lymphoproliferative cancers, those receiving immunosuppressive drugs, including corticosteroids and organ transplant receptions, are at increased risk for shingles. Herpes zoster occurs with higher frequency among persons who are seropositive for human immunodeficiency virus, HIV, than among those who are seronegative. A longitudinal study demonstrated an incidence of 29.4 cases of herpes zoster per 1,000 person years among HIV seropositive persons, as compared with 2.0 cases per 1,000 person years among HIV seronegative controls. The second part, natural history. During the program of herpes zoster, patients report headache, photophobia, and malaise, but rarely fever. The disease begins with localized abnormal skin sensations ranging from itching or tearing or severe pain, which precedes the skin lesions by 1 to 5 days. Pain of variable severity occurs in virtually all patients, with acute herpes zoster. Then the image of herpes zoster. An erythromatous molecular popular rash progresses to clusters of clear vesicles, which continue to form for 3 to 5 days and evolve through stage of pustulation, ulceration, and crusting. Healing occurs over a period of 2 to 4 weeks and often results in scarring and permanent changes in pigmentation. The cutaneous eruption is unilateral and does not cross the midline. Simultaneous involvement of multiple non-contagious dermatomes virtually never occurs in immunocompetent patients, although lesions overlap adjacent dermatomes in 20% of cases. The presence of a few skin lesions outside the primary or adjacent dermatomes is neither unusual nor of prognostic importance in immunocompetent patients. The third part, diagnosis. The presence of herpes zoster is sufficiently distinctive that a clinical diagnosis is usually accurate. However, the location or appearance of the cutaneous lesions may be atypical, especially in immunocompromised patients, and thus require laboratory confirmation. Viral culture is possible, but varicella zoster virus is liable and relatively difficult to recover from swabs of cutaneous lesions. A direct immunofluorescence assay is more sensitive than viral culture and has the additional advantage of a lower cost and a more rapid turnaround time. Like culture, the direct immunofluorescence assay can distinguish herpes simplex virus infections from varicella zoster virus infections. Polymerase chain reaction techniques are useful for detecting varicella zoster virus DNA in fluid and tissues. The first part, postherpetic neuralgia, is the fine needle therapy. It's useful for this postherpetic neuralgia. Postherpetic neuralgia, defined as pain that presents more than 30 days after the onset of rash or after cutaneous healing, is the most feared complication in immunocompetent patients. Both the incidence and the duration of postherpetic neuralgia are directly correlated with the patient's age. The reported incidence of postherpetic neuralgia ranges from 8 to 70% and increases with advancing age. In one study, the overall prevalence of postherpetic neuralgia was 8% after 30 days and 4.5% after 6 days. As compared with younger patients, those who are 40 years of age or older had a prevalence of PIN that was 15 and 27 times as high at 30 and 60 days, respectively. Each 1 year increment age was associated with 9 and 12% increases in the prevalence of postherpetic neuralgia and at 30 and 60 days, respectively. Within the effective dermaton, patients have a variety of sensory abnormalities in addition to neuropathic pain, including odonia, a form of hyperrasthenia in which non-noxious stimuli, for example, a light touch, are perceived as painful. Pain can present for months and socially years. Therapy, the 5 parts therapy. The therapy for Herpes Zoster should accelerate healing, limit the severity and duration of acute and chronic pain, and reduce complications in immunocompromised patients. An additional therapeutic objective is to reduce the risk of dissemination of varicella zoster virus. 3 drugs: aciclovir, valciclovir, and famciclovir are approved in the United States for the treatment of herpes zoster in placebo-controlled trials. Aciclovir, 800 milligram 5 times daily, shortened the duration of virus shedding, halted the formation of new lesions more quickly, accelerated the rate of healing, and reduced the severity of acute pain. Variable benefits were reported with respect to reduction in the frequency and duration of postherpetic neuralgia. A meta-analysis of this data showed that aciclovir was significantly superior to placebo for reduce the duration of zoster-associated pain, defined as a continuum of pain measured from onset until final resolution. Among patients who are at least 50 years of age, the median time to the resolution of pain was 41 days, as compared with 101 days in the placebo group. And the proportion with presented pain at 6 months were 15%, as compared with 75% in the placebo group. Valciclovir, a prodrug of aciclovir, produces serum aciclovir levels that are 3 to 5 times as high as those achieved with oral Antiviral therapy. In a randomized trial of patients who were at least 50 years of age, Velcilovir 100 milligram every 8 hours and Antiviral resulted in equivalent rates of cutaneous healing, while Neuralgia significantly shortened the median time to the resolution of Zoster-associated pain, 38 days with 51 days. The proportion of patients experiencing pain at 6 months was 25.7% in the Antiviral group and 19.3% in the Velcilovir group, extending Velcilovir therapy from 7 to 14 days did not produce any additional benefits. Famciclovir 500 milligram every 8 hours, a prodrug of Princilovir, was significantly superior to placebo in reducing the duration of viral shedding, limiting the duration of new lesion formation, and accelerating healing in a placebo-controlled trial. In a subgroup analysis of subjects who were at least 50 years of age and who had present pain after skin healing, the midline duration of postherpetic neuralgia was 163 days in the placebo group and 63 days in the Famciclovir group. Velcilovir and Famciclovir was compared for the treatment of herpes zoster in immunocompetent patients and were shown to be therapeutically equivalent in terms of both the rate of cutaneous healing and pain resolution. At 6 months, 90% of patients in each treatment group still reported pain because of their superior pharmacokinetic profiles and similar dosing regimen. Velcilovir and Famciclovir are preferred to Aclovir for the treatment of herpes zoster. All 3 drugs are exceptionally safe and well tolerated. There are no contraindications to the use of these drugs. Also, a judgment in the dose is required in patients with renal insufficiency. None of these drugs are currently approved by the Food and Drug Administration for use in pregnant women. There is no role for topical antiviral drugs in the management of herpes zoster. 2 large controlled clinical trials have assessed the role of corticosteroids in combination with Aclovir. In both studies, patients receiving corticosteroids has a moderate but statistically significant acceleration in the rate of cutaneous healing and alleviation of acute pain. Combination therapy resulted in an improved quality of life as measured by reductions in the use of analgesics, the time to uninterrupted sleep, and the time to resumption of usual activities. However, neither study demonstrated any effect of corticosteroids on the incidence or duration of postherpetic neuralgia. Corticosteroid therapy should not be used in patients at risk for corticosteroid-induced toxicity. For example, patients with diabetes, mellitus, or gastritis. Combination therapy using valsivir or famicivir with corticosteroid is assumed to be equally effective, but it has not been studied in clinical trials. The use of corticosteroid for herpes zoster without concomitant antiviral therapy is not recommended. Treatment of postherpetic neuralgia is complex, often requiring a multifaceted approach. Clinical trials have shown that opioids, tricyclic antidepressants, and gabapentin reduce the severity or duration of postherpetic neuralgia, either as single agents or in combination. The adverse effects of these medications can be additive, especially in elderly patients. Topical applications of lidocaine patches or capsaicin cream can provide relief for some patients. In a study of patients with intractable postherpetic neuralgia, intrathecal injection of methylprednisolone acceptable once weekly for 4 weeks resulted in a significant reduction in pain. Additional data are required to validate these promising initial results. Then the conclusions. Herpes zoster can occur in anyone who has had a varicella, but it's more common with increasing age and in immunocompromised patients. The diagnosis is usually made clinically, but a direct immunofluorescence assay may be useful in atypical cases. Acyclovir, valsiclovir, and famiciclovir are approved for the treatment of herpes zoster. These drugs are well tolerated and are similar in terms of both efficiency and safety. However, because of their improved pharmacokinetic characteristics, and simpler dosing regimens. Vaclovir and famciclovir are the preferred drugs for the treatment of herpes zoster. Older patients, especially those over 60 years of age, who have severe pain at presentation, are at increased risk for more severe disease and complications, and should, like the patient described in the case victim, be targeted for antiviral therapy. Antiviral therapy is mandatory for patients presenting with herpes zoster also makers, primarily to prevent potentially sight-threatening ocular complications, to reduce the duration and severity of acute symptoms. Adjunctive therapy with corticosteroids can be considered in older patients who have no contraindications. The potential for severe pain with herpes zoster should not be underestimated, and post-angiologies will often be needed. No single treatment has proved effective for post-herpetic neuralgia. Combination therapy and consultation with pain management specialists are often required. Then the last part, fair needle therapy. Fair needle therapy has a double function of acupuncture and moxibustion, which has both the stimulation of needle and the warm stimulation of moxibustion. As an important part of acupuncture and moxibustion, fair needle has been widely used in clinical treatment since ancient times in China. Fair needle therapy is a treatment method that makes a thick and thin needle made of a special material burned red on the fire, and then quickly steps into certain points and parts of the human body. The fair needle therapy has a long history and has become an important part of Chinese medicine as early as the Huangdi Neijing era. In China, it is recommended to use the fire needle to treat postherpetic neuralgia, but there is no convincing evidence of high-order contribution quality. The evolution of this literature shows that the operation of fire needle in the treatment of postherpetic neuralgia is safe and effective, and the cure rate and the effective rate of fire needle therapy, especially in combination with other therapies, are obviously superior to other therapies. Then the picture shows the fire needle therapy. Yeah, you can see the needles are burned to red. Yeah. Then the two videos to show the fire needle therapy. You can see the doctor is burning the needles. It should be burned to red, and then quickly stepped to the points. This is videos for the fire needle therapy to treat the herpes zosters. Then the second video.
Good.
This is fire needle therapies to reduce the pain of the headache. Yeah. Also need to burn the needles to red and quickly to stab the points. That's all my presentation, and thanks for all your attention. Dr. Steen.
Yes.